This week on the BackTable podcast.
As an RPLND surgeon, you have to have a certain humility about yourself to always be, listening to your colleagues, because there's only a few sort of coaching lines if you look through history of each of us that we've come from. And so I think conversations like we're having tonight are so important to understand how do the other lines of coaching, as it were, how do they approach these things? Because you may have only seen, one or two ways to do it in your training. And it's good to talk to someone who has learned from a different one or two way. And so I think an RPLND surgeon needs to have a certain humility about themselves, because the variety of cases and scenarios that you get into is so much vastly greater than a prostatectomy or a partial nephrectomy or what have you.
This conversation is continued from part 1 in our previous episode.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. This is Aditya Bagrodia as your host this week, and it's my honor to introduce our guest today, Tim Masterson from Indiana University, and Rob Hamilton from Princess Margaret Hospital, University of Toronto. All right, so maybe just like general steps. Let's say it's a not overly complex, somewhat limited to a standard template, standard renal hyla, ureters, crossing, like a garden variety, post-chemo, RPLND. Let's call it a bilateral template. You've gotten your retractors in, maybe you excise the preperitoneal fat with the falci like they did at Memorial. Walk us through just getting exposure to the retroperitoneum.
So, if you're going to do a bilateral template, a lot of times we're going to go up the route of the mesentery. So, I always tell my fellows and residents that you got to be really, really flexible, especially if you're looking at the post-chemotherapy setting, because you don't know, while you can predict, you don't necessarily know where your avenues are to mobilize things well to kind of work on getting the duodenum off, because especially if you have interaortic cable disease or pre-cable disease, the duodenum can be at risk for being stuck to there, and you want to try to minimize trauma to that. So I find the easiest way to find that plane and getting the retroperitoneum off of the mesentery is right off the kind of the cecum. I usually start there, but if it's difficult to work medially, then I'll work laterally on the colon and release the colon off. If the colon is kind of difficult because I've got a kind of a paracable mass, then I'll kind of work medially and work our way there. But just trying to be flexible to try to work both, either caudad to cephalad, medial lateral or lateral to medial, to try to figure out a way to get the mesentery off and work my way onto the duodenum to get that retracted off is something that I always kind of emphasize. Once you kind of get that exposed, I think it's been a long time since I've divided the IMV as far as the left colon. I've pretty much have found a way to kind of routinely get under the IMV and kind of work from medial to lateral to get the left colon mesentery off. I routinely, unless there's a large mass enveloping the IMA, I try to save the IMA a lot of times. So my goal is to save it, not to just routinely divide it, which you can do, but there's about a 1% risk of ischemia in the watershed area between the vasculature to the left colon. So that's the general setup to get everything kind of exposed. And I try to do more intracorporeal retraction instead of extracorporeal retraction, but there's some people that just don't give you a lot of space. They don't have much of an abdominal domain, either because they're muscular, even if they're thin, or if they're big, there's just not in a short mesentery, you just don't have enough space to retract intracorporeally. So I wind up retracting that extracorporeally, but my first attempt is usually try to do intracorporeal if I can.
Yeah, I don't have too much to add. So I find the most preserved aspect of the retroperitoneal anatomy is just medial to the duodenum, actually. So I start my incision of the posterior peritoneum there and carry it down and around the cecum and then up the left side. I find almost always you can execute it that way unless it's extremely distorted from a huge mass post-chemo. Completely agree. Almost never take the IMV. And I think I've taken 3 IMAs in 12 years. So I really try hard to preserve that for the reasons that you say, unless it's absolutely encased in tumor. I routinely Cattell brash the entire right colon and small bowel, put it in a bag, put it on a chest. That is our routine that we've always done in Toronto. And, you get immaculate exposure bilaterally, because we always do bilateral, so bilaterally to the retroperitoneum. So it sounds like that's a difference between your approach and my approach, Tim.
Yeah, no, the only things I would maybe add is, I also don't take the IMV. I do try to dissect out that thick lymphatic packet just medial to the IMV and divide that, and then, really try to get my leftward retractor, which is going to be on kind of the tail of the pancreas, to the left of the SMA, which you don't want a retractor on, I believe. So I'll retract that. And I also leave the IMA intact. I got to say, I do hate flipping the colon back and forth. It's kind of brutal. It just, it can be clunky. I won't take the IMA to not have to flip it back and forth, but I'll get as much done as I can. And this is, again, where I think, if they've got a long, favorable aorta with the IMA being relatively low, close to the bifurcation, you got plenty of room to do the bulk of your RPLND. And then even if you have to flip the colon just to finalize the distal aortic, left common iliac, it's not so bad. Does that sound all right?
Yeah, I guess I would say that I'm a little bit more liberal about dividing the IMA if there's bilateral disease around it. I've certainly divided it a lot more than it sounds like Rob has, but I think that if you don't have to, it's nice and you can minimize that risk to the patient. Some patients set up really well where you can kind of work around it. You can kind of skeletonize it, you can do your nerve sparing if you're doing nerve sparing, and still be able to work both above and below the IMA on the periaortic side if you're coming in from the right, and be able to dissect that nodal tissue. But it's kind of like the same thing, how much torture you don't want to put yourself through, right? You keep your incision small, you keep your IMA intact. This just adds to the time and the tedious nature of the operation. But I think in the big picture, it advantages patients by minimizing that risk of any sort of bowel ischemia. So it's worth it to me if I can do it.
Yeah, I kind of agree. If I feel like, as you mentioned earlier, Tim, with your sharp tool between like the common iliac going to the aorta, if I just want to have it all right there, I'll resect, divide the IMA, and then resect that bit of the sigmoid mesenteric, keeping the marginal artery intact, of course, just to have it all laid out over there. So I totally get it. So we've got an exposure. I'll toss out my next typical step is to find the ureters. There's so many opportunities to ding things up if you're not thinking about the DUI, the ureters, the kidney, the hilum, the pancreas, the colon. If you kind of slip, there's a real chance for a miss. So that's my next step. I'll throw it out to you all. Once you're exposed, what are kind of the next steps?
I can go first this time, Tim. So I find the left renal vein, and Tim, you made allusions to retroaortic renal vein like that, because that's such an early step in your trajectory. When you don't have that usual position left renal vein, then it's like missing a friend. So you start left renal vein, and then I control all those lymphatics. Those are big sources of chylocystitis, in my opinion, is those lymphatics that course over the left renal. And then I incise down the IVC right in the middle, all the way down till, right common down to the right common iliac where the ureter crosses the right common. And that's where I set up, usually at least open. So I do it a little differently robotically, but open. I always start my operations with the intra-aortic cable package first. That's the first thing I do. Then I go periaortic, then I go paracaval as my last step before spermatic cord. So I can stop there, but that's my next steps.
Yeah, I'm a little bit more schizophrenic with my operations because we're not always doing a bilateral template, and so the process is a little bit different. But it also depends on the distribution of the disease for me a little bit. I always tell my trainees that are in there that I've spent most of the first, 50% of my operation just getting all the things I don't want to harm out of the way, right? It's ureter, it's kidney, it's setting up the bowel retraction, the mesentery to the colon. So I'm doing everything to kind of get everything out of the way. So when I'm ready to do my node dissection, I'm looking at the retroperitoneum, and it's just the vessels and the lymphatic tissue, getting the gonadals out of the way and getting those submitted and resected. So that's the most important kind of first step. I'm pretty tedious about that process. And then you can just start saying, how you can approach it. I like to get on the renal vein early because I like to set my superior border. I also then will skip to my caudal border, because one of the things that I think is a little bit of a risk is when you're splitting on the cava, you need to know where the iliac crosses over, right? Because you want to know where that terminal aspect, and if you get a right angle to any trainee, they're going to keep going until they reach China. So So you always need to make sure that you understand kind of where that caudal extent is. And plus, if I'm nerve sparing, I kind of want to set that border on the iliac artery, common iliac artery, where I want to stop, where I know where those pelvic trunks, the terminal aspect of the hypogastric plexus crosses over. So I know where I'm stopping there too. So I kind of want to find those aspects early from a surgical standpoint. And then once I do that, then I split and roll on the vein, and roll on the aorta. And then I start, harvesting packets and doing nerve sparing if that's relevant.
Yeah, and absolutely, Rob. I mean, I agree. The left renal vein is a good friend, and maybe just an extension of the retractors, taking that thick lymphatic by the IMV, ones coursing over the left renal vein, which are, closely associated with the SMA. Make sure you know where your SMA is. And when you get your retractors on, essentially I'll get both of them cranially oriented, one to the left of the SMA. Like to see that anterior surface of the cava, the renal vein ostium coming in, and then the second retractor anteriorly oriented is going to be essentially directly anterior to the cava. So the exposure, couldn't agree more. There's all kinds of, I think, tips and tricks, putting a little bit of retraction on the retroperitoneum and literally pulling the whole thing inferiorly, and all those lymphatics from the back of the dewey, the back of the pancreas, really show themselves so you can control them, however so you best control them. Perfect. So then, there's nothing algorithmic. You can't just say every time I'm going to start over the right common iliac, split up to the renal vein, and then go from where the cava crosses at the common iliac and split up. I mean, you have to kind of take what you get. I think having a general plan, but start where it's easy. You can start understanding anatomy, especially if there's distortion, displacement, some of the problematic things. But I guess what you're describing is split and roll. Let's talk about vascular control. Every case, are you going in and trying to get proximal and distal controls?
So it totally depends. And Tim, I want to hear your thoughts too. So if it's a case where I know that there's a 100% chance I'm going to enter a great vessel before this day is over, or have to resect a portion of and deal with that, then I absolutely get proximal and distal control first. But I would say that's probably the minority. And most of the time, you just proceed with your dissection. And as long as you can get fingers on it and stop the bleeding and communicate with anesthesia. And if you're unlucky enough to get into that bleeding, well, then you got to put a finger in the dike and then go get your proximal and distal control. So it depends on the case and how comfortable you feel with that dissection. So I don't always do it, to answer your question.
Yeah, I would say that probably 90% of the time, the volume of the disease that you're dissecting doesn't necessarily warrant an intentionality to proximal distal control. I will say, though, in the cases where you have more advanced disease, bulkier disease, it is imperative. And I will say probably Rich Foster, I have to give him a lot of credit because he really hammered this point into me early on in my career at IU, and he was so systematic and methodical about making sure he had proximal distal control when he had more advanced disease, because it's going to save your backside more than you know. Because if you start working on a large mass on the cava and you start dissecting and you're like, well, I'm working cephalad to caudad or caudad to cephalad, whatever, and you say, I'm just going to kind of work along this plane, and you get into it, it may be a situation where you may, if you don't have lumbars controlled for, you don't have, you got to think about what you're doing. And that's where, you talked to before, what are the risks of the operation, catastrophic bleeding, intraoperative death, we say that should be very, very low because of understanding these principal techniques and making sure that you keep yourself safe. And the way that you do that is making sure you get control. If you think that you have a difficult dissection, I've had this conversation with myself out loud in the operating room where I said, I may get into trouble. I need to stop. I need to get my control proximal distal and establish it and then tackle it. And it's a great exercise to go through and remind yourself, because if you don't, you can get yourself in a pretty difficult pickle. So.
And I would just add, and I thought of a quote from Dr. Scheinfeld that I often use, which is, he used to say, you do the easy stuff first and the hard stuff becomes easier. And so that mass that's stuck to the cava, don't do that first. Do everything else. And if it flies off and now you're just left with this thing that, it may walk you into the vessel, but you've got gorgeous exposure proximal distal, so you don't have to have immaculate control if now you're going after the last thing is just hanging off that cava, because you know you can very easily and quickly get control because you've already done the easy stuff. So, Tim, you made me recall that line from Dr. Scheinfeld, do the easy stuff first and the hard stuff becomes easier.
Yeah, I agree. And, one of the things that I think is challenging, so generally outside of like bulky pelvic disease and so forth, getting your iliacs controlled is I think somewhat more straightforward. Pelvic disease, intrailiac disease can be a bit challenging. But sometimes I feel like the most potentially offensive cases are upper retroperitoneal, infrahilar, suprahilar, encasing the hyla. And, to actually get proximal control, like say on the aorta, are you getting superciliac control? And maybe I'll just ask the question, is that typically, are you getting beyond any potential desmoplastic disease and getting aortic control, or how does that actually look like in your hands?
I would say it's very rare in my experience that you need that. In those cases, that's the cases where I've contacted vascular ahead of time. They've reviewed the films and we have a game plan. And we might get superciliac access so that and have an umbo tape around there so you can go fast if you need to. But I would say that's exceedingly rare.
Yeah, I mean, I would agree. If you have a practice where you're going to be doing a bunch of post-chemotherapy node dissections, you're going to see enough of these patients. And you talked about preoperative assessments and considerations. The first thing I'm doing when I'm looking at a mass is radiographically is where's my control going to come from? Can I get infrahilar control below the renal arteries and, vena cava and the renal veins if that's relevant? Distally, how far does the disease go to the bifurcation? One of the hardest places is that space where the vena cava branches and that left renal vein goes under the iliac arteries. That's a hard place to have a problem vascularly because it's difficult to control the venous inflow from the pelvis and the pelvic veins. And so I spent a lot of time looking at that. So this disease is complicated enough that if you're going to be doing these cases, you need to have a good sense of how you're going to set that up for yourself. And you shouldn't be any consideration or question about how that's going to come. You can't say, well, I'll just figure it out if you're doing bulky disease. You've got to have a plan ahead of time. But most of the time, once you understand those basic principles, and it's not rocket science. And I actually use that line from Joel Scheinfeld, do the easy stuff first and the harder stuff gets easier. I've said that I don't know how many times from learning that lesson in fellowship, and it's true. You can make a lot of very, very challenging cases look a lot easier by following those principles. But
I agree, and I mean, I think that's always kind of got to be in the back of your mind. If it's a relatively more straightforward case, it's mid-great vessel, you can usually develop above and below. I think one of the things I'll always drive home to the residents and fellows is it's not like a big kidney where it may be hot and heavy for 2 to 5 minutes and then it's over. There is no quick exit plan, typically speaking. And, if you've got 1.5 inches of desmoplasia and you're trying to dissect off the major vessel and you got a hole, that's a problem. And, that would be, ideally you don't do it. But if you do, you stop it, you get proximal control, you get distal control, whatever that looks like, and then you can sort it out. But that's, I think, a perfect point that it's got to be in the back of your mind and you're part of your planning intraoperatively and preoperatively. So I'm going to take this as a foregone conclusion. I think that all lumbar vessels should be divided. That's a part of the operation to make sure you've completely liberated the vessels. And all right, Rob, I'm getting some shaking heads here.
Yeah, so I know this is, in the literature, this is often a bone of contention. I would say that obviously if the lumbar vessel is involved with cancer, of course it should be resected. But we have taken the stance for years, and I've inherited this from Dr. Michael Jewett, that if the lumbar is not involved, or if you can dissect it off the tumor, which is often the case, then you don't need to resect it. So all lumbar veins go. That's a no-brainer. We don't think there's consequence to that. Lumbar arteries, we try and preserve unless they're involved.
I know you guys have published on it's a risk factor for recurrence. Is that an evolving field, or that's kind of your practice and you go with it?
yeah, I mean, Sloan Kettering has had data they published on that. We've published on reoperative RPLND and the risks, and not resecting, widely resecting the gonadals, not taking the lumbar artery. So I think in a routine case, I routinely will take them. I mean, for me, yes, we do it on the vein because it allows you to get into that retrocaval space. I would argue that, especially if you're doing bilateral templates, a lot of times that also helps you kind of mobilize the aorta, depending upon your approach, to just be able to get on both sides of it to manipulate it. Because when you're still tethered with the lumbar arteries essentially centrally on the aorta, it makes it a little bit more difficult to mobilize and expose, depending upon how you, set up your case. But the way I do it, it helps me, and there's not a lot of risk to taking those 6 branches below the renal hilum. If I am worried about retrocrural or posterior mediastinal disease, I will intentionally try to save as many branches as I can to make sure I optimize blood flow to the spinal column, because spinal ischemia is certainly a risk, and we talk about that with patients, but you kind of know that ahead of time. So I can get those out of the way and create mobilization for the aorta, because a lot of times, especially if I'm routinely preserving the IMA, I'm tethered anteriorly and then I'm tethered posteriorly if I don't take those lumbar arteries. So this helps me elevate the aorta up and get all the tissue around it, so it helps me.
I think these are all excellent points. I mean, sometimes older patients, I'll try to leave a couple lumbars in. My practice has typically been to take them, and even if it's, a dominant periaortic mass, I just feel like getting that medial mobilization gives me some maneuverability that makes the remainder of the, heavy lifting of the operation safer. Ever find yourself in a subadventitial plane?
Sure.
But sometimes you have to. You can't do it for a long period of time. If you're talking on the aorta, that is, you can't do it for a long period of time, but certainly for a short surface area, sometimes you have to completely resect the specimen.
Yeah, I think it's important to recognize that plane when you see it. I mean, it's not looking at an absolutely avascular white surface of the iliac or the aorta is not something you want to see. So it's usually, once I see it, I usually try to find my way to try to get out of it. So it's not like Rob mentioned, it's not a long surface or a large surface area that's involved with it. I don't know that we really have any data that suggests what the long-term risks as far as aneurysms or things like that would go along with it. But in my mind, it seems like that's a logical risk that I want to try to mitigate as much as I can. But when you're dealing with post-chemotherapy masses and the desmoplasia that's around them, whether it's, just a very desmoplastic non-seminoma, but certainly if you're doing any post-chemo seminomas, and we've all been there for those, they're difficult to necessarily find the right plane, and you kind of have to pay attention. I wear magnification loupes when I'm doing my cases, so I think that helps me just see things a little bit better. I don't think it's imperative. Dr. Carey at our institution does not, so it's not an absolute, but it's something you want to try to minimize.
Yeah. I mean, nothing to add. I think the biggest thing is to recognize it. I haven't looked up the primary reference, but one of my mentors, Art Sagalowski, tells me about an early series of 5 patients that had a subadventitial dissection, because it can be a more readily identifiable plane, and then 4 out of 5 had an aortic blowout or something awful. So I think recognizing it. So I really appreciate the thoughtfulness to approach this safely is really kind of the punchline. It comes across to me that extremely thoughtful and careful and familiar with this operation. Talk a little bit about Chyle leak mitigation. This is if it happens, my numbers that I have for post-chemo are kind of on the 1% to 3% range in my hands. It's tough. It's obviously brutal for the patients, and I don't want to maybe go into full management as we approach an hour and 20 minutes, but what do you do at the end of the case to make sure that you're not leaving this patient with problematic Chyle leak?
We talk about the advantage of repetition and volume and doing these cases. Every time you do a case in a heavy person, every time you do a case in a skinny person, you learn a little bit different about the anatomy. I give these patients, Joel had long time ago talked to me about a high-fat diet beforehand, and I routinely do that because it accentuates the amount of Chyle. But it's interesting, you learn all the places where the lymphatic channels can be, medial and just underneath that, the IMV, when you're releasing the left colon off, that's where a lot of those lymphatics are draining into that common plexus that courses over the renal vein. That's an area where I've had my biggest lymphatic leak. The only time I've had to take a patient back to reoperate on them because he couldn't stop eating pizza and his lymphatic leak would never closed. So I went back, and that's where it was. It was right along the IMV, anterior to the aorta. When everything was done, it was interesting. It was a pristine plane, and I just sutured it, and then it was done. But so surprisingly easy fix from a surgical standpoint. But I think the more you do this operation, the more you really appreciate where all these lymphatics course, and you have to think about both ends of your plane of dissection. If we're doing a modified template, we have to worry about, if we're only doing a right side, we have to worry about those lymphatics as we divide them overlying the aorta, so we don't get retrograde lymphatic leaks from the left to right side. And certainly on the upper ends and caudal ends of your incision over the renal vein, behind the crus of the diaphragm, and then over the iliac vessels, I wind up using a lot of clips and ties to kind of secure those. And I think that, and Rob can probably talk about this, I think what you've seen over the past 5 years is you get these kind of case reports of robotic RPLNDs being done. They're having really, really high rates, up to 25 or 30% risk of Chyle ascites, because they've got pneumoperitoneum that suppresses lymphatic leaks outside of venous bleeding. And so you don't really appreciate, when they kind of just bipolar or dissect with cautery or whatever energy devices they're using, and they're seeing these high rates. I think people are starting to learn the risk of a lymphatic leak in that population that they're starting to do. So I think you're starting to see more and more publications over the past year showing lower and lower rates, but I think it was a learning curve for them initially.
I don't have a heck of a lot to add to that. I do think that, among the community of surgeons who do high volume RPLND, this is a topic that gets bandied around often through emails. And I can't remember, Tim, if you were on this, but recently there's been I can't remember how many there were on that email. There's probably been like 6 surgeons on that email. And this is a common problem with not a lot of great, or I shouldn't say a common problem, a common enough problem among high volume centers doing post-chemo RPLND with not a lot of great science to say, like, here's where the lymphatic leak always happens, as you alluded to, Tim. So we just do the best we can to mitigate it and the best we can to manage it post-operatively. I completely agree with high-fat diet pre-op. I did borrow from our robotic colleagues who started doing low-fat diet post-op, and to the extent that that helps, I don't know that we know, but I've started doing that not just for my robotic cases, but also for my open cases. I actually switched to using ligature instead of clips because I hypothesized that sometimes the clips actually fracture the lymphatics. And now you have a clip with a more proximal fracture on your lymphatic, and the lymphatic can't heal itself because you've got a giant piece of metal across. Cautery, I agree, is not a great sealant of lymphatics, but ligature at least purports itself to have the technology to be able to seal lymphatics. And so that was a big reason why I switched, and I found my rates did go down. I use very little clips now, and now a lot of ligature, and I found my rates have gone down. Well, you said you didn't want to get into management, Aditya, but I've seen it all and done it all in terms of management, whether it's low-fat diet, TPN. I've had 2 reoperations in 12 years. I've had lymphatic embolizations, and I've had to send 1 or 2 down to Philadelphia, where they have a specialized center for MR lymphatic imaging and interventions.
No, I mean, I'm happy to talk about it, Rob, and I think it is one of those things when it happens. Actually, one of my mentors, one of his last cases was a Chyle leak, extended, complicated Chyle leak, and honestly, I think it kind of sped up him hanging up his hat. It can really be something for all parties involved. And, Tim, your all's group put out a nice paper in Urologic Oncology, kind of walking through your algorithm, which I certainly refer our trainees to and think about myself. I'll just throw this out there. My kind of general is dietary modifications. Usually I'll try to get by with 1 or 2 paracenteses. Many times that's sufficient. If not, borrowing from our transplant colleagues, I'll put a drain in and see if just kind of keeping the whole abdomen collapsed allows for whatever's leaking to seal off. If that's not, really kind of panning out, then it's more NPO, TPN. I've heard kind of mixed reviews on octreotide. We haven't really, somatostatin, haven't really utilized that too much. And then lymphangiography, which I think can be diagnostic and therapeutic. One patient, not of mine, it was in training, had a Denver shunt. Be curious to hear your experience with that. And then taking a return trip in is kind of, I don't know, just off the cuff, an algorithm. What do you think?
Yeah, I will say we manage it pretty similar, and we try to be more conservative. We tried doing a low-fat diet afterwards, for 4 weeks, and patients hated us. So we made it 2 weeks arbitrarily, and we use it as a guideline because a lot of times these patients want to try to do things that help their recovery. And if they think that they're doing something proactively, even though it may not, there's no evidence to show that it helps, then they're happy to do it. So a lot of times we're just doing it from the psychology of the recovery process more than anything. In the setting of a lymphatic leak, I will say this: paracentesis is reasonable, especially if it's a relatively serosanguinous drainage. If it's pretty overtly chylous, I'm pretty aggressive about getting a drain in earlier. And a couple of things that I would comment on is I have a lot of pushbacking. So, when you talk about destination care, a lot of times if we have a chyle leak, we're trying to manage this in communities outside of our own. And so I get a lot of pushback trying to get a retroperitoneal drain. They just want to put a trans-abdominal drain, but you really want to try to get the drain closer to the source, which is going to be in the retroperitoneum, right? And so I'm always trying to get them to put it retroperitoneal. They always want to tunnel it for some reason. I don't find that there's really any benefit to tunneling it. They think that there's less of a risk of seeding it or colonizing it, but we put, JP drains in patients all the time without tunneling them. So I fight that a lot, but so I don't think you need to have a tunnel drain. I think you want to try to get it closest to the source, and you want to try to get the output as low as possible, as quickly as possible, because the longer this goes on, the more epithelialized the tract of the lymphatic leak becomes, and the harder it is to get it to close. And then if you can't get it closed right away, then you're going down the pathway of sclerotherapy or shunts or surgical intervention to try to close it. So you want to try to be, if it's going to be a case where it's going to be high output, you want to kind of try to manage that as quickly as you can. So if you do a paracentesis and they fill back up in 3 days, then you're going to be better off just putting a drain in.
Well, it is individualized, it's nuanced, it's worth getting right, and there's, not a lot of good data. I do think it's probably worth scouring the transplant and hepatobiliary data one more time just to make sure there's no other tips and tricks. And I guess to me, it really drives home, maybe it's been a long day at the office. You're kind of ready for it to be over. You really got to do your due diligence until the 11th hour, check all the common spots, maybe clip the cruise to the diaphragm. I know that's something Dr. Scheinfeld did. Check all your, common locations behind the right renal vein, at the SMA, medial to the IMV, and give it a due diligence. And even fascial closure, at that hernia risk is not trivial. So to kind of stay focused till it's really done, I think can be overemphasized. Well, Tim and Rob, your expertise, your knowledge, your enthusiasm is so appreciated. I can't believe it's been an hour and a half, and I thank you for your time. But maybe in the last, just some parting thoughts to the listenership as we conclude. Would love to hear it. Tim, let's have it.
Yeah, I think we had talked, Aditya, recently, about who should be doing these operations. And so I guess I'll comment a little bit on that, since that's one area we haven't really addressed on is, these are young patients with a lot of, at risk when they're coming in, especially in the post-chemotherapy setting where you're trying to do things to minimize the risk of any salvage therapy. So, I would say for those who are listening, if they're coming across these patients and you're comfortable with this operation, go for it. I think that's, everybody has to make that decision for themselves, but you don't want to do anything, that compromises the safety or the control or the ability to optimize the cancer outcome for these patients. And so if there's any question, there's always resources for, destination centers to help manage this, or even just a phone call to say, hey, can you look at this? What are your thoughts? And what risks do you perceive maybe coming into play? But yeah, I guess I would leave it at that.
Yeah, I mean that was going to be my concluding thoughts too. I think you have to be personally dedicated to the craft and to that patient that you're looking after that day. And a lot of that came up in what we talked about today for preparation and thinking about all the options for trouble and how to bail out of that trouble. So you can't have 4 other operations going on, your grant that you're writing in the background and skipping in and out of your case like that. You have to be dedicated to that young man that's on the table that day. I think also as an RPLND surgeon, you have to have a certain humility about yourself to always be, listening to your colleagues because there's only a few sort of coaching lines if you look through history of each of us that we've come from. And so I think conversations like we're having tonight are so important to understand how do the other lines of coaching, as it were, how do they approach these things? Because you may have only seen, one or two ways to do it in your training. And it's good to talk to someone who has learned from a different one or two way. And so I think an RPLND surgeon needs to have a certain humility about themselves, because the variety of cases and scenarios that you get into is so much vastly greater than a prostatectomy or a partial nephrectomy or what have you. And so I think you have to keep that humility as you go about you through your practice. And that saying of lifelong learning is so true for an RPLND surgeon.
Well, I think that perfectly captures it. Tim, Rob, thank you for your time, for your devotion to the craft, as it were, and for your expertise. Really appreciate it.
Hey, thanks for the opportunity.
Yeah, thank you.
Thank you so much for listening. If you haven't already, make sure to follow, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, you can direct message us at _BackTable Uro on Instagram, X, or LinkedIn.
BackTable is hosted by Aditya Bagrodia
And Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.